Dear Professor Pawankar, dear Ruby, dear ladies and gentlemen, dear Luo, it's a great pleasure to meet you today, although virtually, and discuss the latest development in phenotypes, endotypes, and its clinical consequences, which is a topic extremely important for chronic rhinosinusitis as it is for other organ systems, and which, as I will tell you, changed and will even more change our clinical life tremendously. We are used to talk about chronic rhinosinusitis with and without nasal polyposis as the phenotypes we recognize based on the presence of non-presence of nasal polyps in the nose. Now, of course, we know that this is not covering everything. Sometimes we discover nasal polyps later during surgery, for example, but we didn't see them in the nose. And sometimes a patient with a chronic rhinosinusitis without nasal polyps develops into polyposis, although this is very seldom. We do understand that obviously there are differences in remodeling, which is what we see actually. And these differences are translated, but not one-to-one, to inflammatory differences. We had the impression so far that the phenotype, chronic rhinosinusitis with nasal polyps, was driven by type 2 inflammation, which is IL-4, 5, 13, T cells, Th2 cells, eosinophils, IgE, and chronic rhinosinusitis without nasal polyps rather by non-type 2, Th1, Th17, IL-1 beta, IL-17 interferons. But you will learn that this is not quite true. It's much more interrelated. However, it is very interesting that we understand the transition from phenotypes to endotypes. Phenotypes are the visible morphology in the nose, for example, whereas an endotype is a condition, a pathobiological mechanism that defines the inflammation and also, as you will see, has enormous consequences for what comorbidity of this disease, for example, is. So endotyping started when we looked into specific cytokines. In 1997, we showed that interleukin 5 is so specific for nasal polyp disease, whereas we didn't find it too much in the non-polyposis CRS. We also showed that IL-5 is directly related to eosinophil apoptosis, and of course this was supported by work from many others, also Ruby Pawankar, on eosinophils. And with Gunnar Johansson in 2001, we discovered that also IgE is not only present but plays a role in this local eosinophilic inflammation. And this is something that translated later also in the discovery of IgE to specific allergens such as staphylococcal enterotoxins. Now today we have a much better view on these endotypes, and I will show you this slide from 2016, the JCI paper from Peter Thomassen, more later and discuss a little bit more, because this was not the end of the story, but it is a very important step in understanding the diversity of chronic rhinosinusitis and its consequences in terms of disease, in terms of comorbidity, in terms of recurrence after surgery. We then, together with Zhang Luo, also looked into the diversity of T-cell repertoires all over the world, and we could find that there were clear differences between what we see in Europe here as Benelux, very type 2 driven, versus Beijing, versus Chengdu, where there's only little type 2 driven disease in patients with nasal polyposis. So the first thing we learned was that nasal polyps is not all type 2. Even in our country, in our place, not everything is type 2. There is also non-type 2 nasal polyposis. And second, we learned, and with other colleagues together, that there are obviously changes over time. And we will probably see more and more type 2 inflammation in the future, in Asia, and even in our place in Ghent, where we already see a lot of type 2, it seems to increase further in severity. Recent work, and that's what I want to start with, is actually in chronic rhinosinusitis without nasal polyps, which we considered a type 1, type 17 disease. And we figured out that, of course, also in CRS without nasal polyps, and this is the right panel of slides, you not only find neutrophils as a typical representative of type 2, type 17, but you do also find eosinophils, such as you do that in chronic rhinosinusitis with nasal polyps. We looked at their symptoms, or let's say, let me repeat. We looked at the clinical symptoms of those patients which we defined as type 2 versus those patients who were non-type 2. And in CRS without nasal polyps, this is about 50-50. And we found no difference between these different endotypes. However, the inflammation markers were tremendously different. And what you find here is this differentiation into non-type 2 and type 2 CRS without nasal polyps, just based on IL-5, as you can see it on the paragraph A. But you see consequently in B, C, D, E, that this is reflected also by IgE, by Staphylococcus enterotoxin, IgE, and as you see further, by IL-17 in just the diverse, in just the other way. IL-17 is very typical in non-type 2 CRS without nasal polyposis. So we understand now that not only in nasal polyps, but also in non-polyp CRS, we do find type 2 and non-type 2, or in that case, type IL-17. What is the clinical relevance of type 2 inflammation if it's not a difference in symptoms? Well, as very much alike we saw in nasal polyposis, we do see more recurrence over a period of 8 years in those patients with type 2. We do see more asthma comorbidity, although there was no significant difference in allergies. In other words, if not in the symptoms, certainly in comorbidity, certainly in the perspective of the disease, type 2 versus non-type 2 also is relevant for chronic rhinosinusitis without nasal polyposis. For nasal polyps, we have shown that repeatedly, and I think it is very clear now that this type 2 inflammation in nasal polyps translates into asthma comorbidity. And here we have, of course, different figures from CRS without nasal polyps. We have asthma comorbidity in up to 70%, and this is very down here on the graph, where you have a severe eosinophilic type 2 SE-IgE positive inflammation versus a moderate inflammation where asthma comorbidity is in the range of 30 to 40%. Nasal polyposis specifically is type 2 prone, and we know that those patients also would have a much higher recurrence rate. So we again have endotyping not as la pour la, but really with clinical consequences in differentiating the prognosis of the patient and probably also the treatment. And I'll come back to that in a minute. This is our very new table just in press in JCI, where we actually look at the current knowledge. And as you see, chronic rhinosinusitis without nasal polyps is 50% type 2, 50% non-type 2. Type 2 inflammation is not as severe as it is in nasal polyposis. And in chronic rhinosinusitis with nasal polyps, you have 85% type 2, which you can differentiate into moderate and severe. And as a consequence, of course, you have phenomena like eosinophils, chronic Charcot-Leyden crystals, IgE formation, SE-IgE formation, and that again is linked to asthma comorbidity and recurrence. So if we realize that chronic rhinosinusitis is not one disease, but it's endotypes, it's phenotypes and endotypes, and these endotypes are actually driving the prognosis and the clinical presentation of the disease, wouldn't that have consequences in how we treat these different diseases? And that is what we are currently working on, trying to figure out whether certain constellations of this disease would need to be treated effectively by different mechanisms, different approaches, whereas to use the same approach in everybody would be an overtreatment for many. So we have to differentiate, and specifically in the age of the biologics, with the advent of the biologics for the future, of course, we will have to exactly know which endotype is presently the patient actually suffers from, and how we translate that into clinical and therapeutic consequences. So far for CRS without nasal polyps, we don't make any difference in phenotyping and endotyping. So endotyping has no impact on the treatment so far. And we do have to learn that, but we do have also to figure out how we diagnose this endotype in CRS without nasal polyps, which is much more difficult than in nasal polyp disease. In polyps, we treat pragmatically with nasal steroids. We increase the dose, we go to short-term systemic corticosteroids, and as you see on the right side, that we go to surgery if this medical treatment is not enough, go back to medical treatment, do revision surgery, and we do have about a third of our patients with nasal polyps ending up in a vicious circle between revision surgery, medical therapy, obviously not really knowing how the next step should be to get them out of this vicious circle. Because let us not forget that patients are not only troubled by their disease, but also by the consequences of the disease management or therapy. Think of systemic corticosteroids, think of complications of surgery. So we have to make very sure that we select the right patients for the best treatment, and that is our task for the next decade. Surgeries, as we have learned, are liked by the surgeons, but are not necessarily leading to what we actually aim at. And specifically not if we have to do repeated surgeries, such as in nasal polyposis. This is work from Sven Seis, the Löwen group, and we see here impaired smell, for example, is increasing with the number of surgeries. So that's not what we want. And that's where we have to decide early what is the best treatment for that patient, also to avoid this loss of smell, for example. One of the possibilities is, of course, differentiation of surgery. And I don't think that this endoscopic sinus surgery, as we understand it at the moment, which is more or less removing polyps, opening the sinuses, removing polyps, but having the mucosa still in place, is the right concept for a disease which I just told you is really a mucosal disease. It's a type 2 inflammation in the sinus mucosa. And funnily enough, even if you have type 2 inflammation in the nasal mucosa, this does not translate into nasal polyp growth, as we all know. So what we came up is a approach where we try to remove the sinus mucosa as complete as possible, but remain on and don't touch the nasal mucosa, because this mucosa doesn't have the potential of forming nasal polyps. And this approach we have called Reboot, and there is more and more work on that. And actually, it is targeting to reduce the inflammation in the sinuses, and we just have published a paper to show that this is possible. But on the other hand, also to replace the sinus mucosa by nasal mucosa, which of course then from the edges of the surgery grows into the sinuses and covers the sinuses within 6 to 8 weeks very nicely. We have seen in small preliminary studies that in fact we can prevent or we can reduce the number of recurrence over 2 years. I'm just looking at a 5-year follow-up of these patients. And we see, of course, that there is a post-operative phase where the new mucosa from the nose has to grow into the sinuses, which might be sometimes a bit troublesome, especially if there are infections. But normally it works now very nicely, and we end up with a covered, but of course clearly surgically manipulated view on the mucosa in the sinuses, in the frontal sinuses, and these patients have the potential to stay polyp-free. They do have, of course, a certain risk for their smell also. The other way, and innovative way, of approaching CRS with nasal polyps type 2, and there we have to really be sure it is type 2, and we can discuss that later, how we actually identify these patients with type 2 severe uncontrolled nasal polyposis, is monoclonal antibodies or biologics. And since 2006, several studies have been performed with anti-IL-5 antibodies, anti-IgE antibodies, and finally with an anti-IL-4 and 13 combined antibody by approaching IL-4 receptor alpha, and finally also anti-IgE. And I just want to show you shortly the phase 3 drugs, the phase 3 trials I just want to show you shortly the phase 3 trials to let you understand the potential of these drugs. When we treat with biologics, of course, we aim at certain specific molecules or structures, such as IgE, the Omalisumab approach, such as IL-5s, the free IL-5s that cannot bind to eosinophils, for example, and prolong their survival, such as IL-4 receptor alpha, dupilumab, which actually prevents binding of IL-4 and IL-13 to this receptor, and by that prevents a whole range of different activities very important for type 2 immune reactions. The Sinus 24 and Sinus 52 Liberty trials were actually just published last year, showing phase 3 trials in more than 700 patients over 24 or 52 weeks, and from there we have the names, with dupilumab subcutaneously 300 milligram every 2 weeks in principle versus placebo, and there was a variation of the dosing of dupilumab also with 4 weekly injections. These patients are uncontrolled severe chronic rhinosinusitis in terms of that they have a lot of polyps, a polyp score of about 6, but certainly they do have prior surgery. 63% of these patients had prior surgery. They had oral or systemic corticosteroids before, and they still suffer from a loss of smell. 78% of these patients were anosmic. They have asthma comorbidity, and also in about a third of the patients, aspirin sensitivity. So from that aspect, they're clearly severe uncontrolled disease. Now, when we treated these patients with dupilumab, we saw in the verum group a decrease of about 2 score points in the nasal polyp score within 24 weeks versus placebo. Now, this tells you clearly that this approach is correct. This approach is functional and effective. IL-4, IL-13, presenting the type 2 immune reaction, actually is an effective approach. It reduces the nasal polyps. If you continue to treat, and this is on the right side, the Sinus 52 trial, you have an additional reduction of the nasal polyp size, and it translates into symptoms such as nasal obstruction or congestion, which you find in the panel B, and you clearly see again there is an effect of the drug. It relapses if you stop, and that is also something we have to learn, that we have to use these monoclonal antibodies continuously. But if we continue to use them, we have an additional effect over the next half year of treatment. This is a perfect principle, proof of principle for the notion that this is a type 2 immune reaction, and you will see the same with anti-IL-5 and anti-IgE approaches, but of course to a different extent. So the quality of the treatment, the effect, the maximum treatment effect, might be different between these different treatments. We see a great effect on the loss of smell, and this is actually something that comes very early, just between 2 and 4 weeks. 80% of those patients who have an effect, who can get smell back, get out of anosmia with this treatment, and then go into a plateau, as you see here on the right side, measured with the APAACI score. So in many of these, we make smell possible again, and this is what patients come in into your room when they have this treatment after just 4 weeks and say, "Doctor, for the first time within 5 years, I can smell again." It's a really tremendous adventure for the patient. We can document these effects over a year in a CT scan, and you see here a patient who has been treated from January 2017 to 2018, and you see very nicely that all the polyps disappear in that patient completely, although this is not the rule. In many patients, you have a partial response. And you see also, of course, as a consequence of this disappearance, the reduction in symptoms and the increase in quality of life in these patients. You have an effect on the lower airways. Asthma works in these patients just with the same principle, a type 2 immune reaction. So you can increase in those patients with comorbid asthma lung function and decrease the asthma control questionnaire, which means you have a better control on the asthma of these patients. But what was very convincing was the effect on the need for surgery and need for systemic corticosteroids within that year. And here you see the two curves, those with placebo and those with dupilumab treatment. And there was a reduction in the need of systemic corticosteroids by more than 70, and the reduction in the polyp surgery, which was a small number, by more than 80% of the patients. So under the treatment, you're obviously not reaching only a sort of a symptom-free status or less symptom status, but also you avoid surgery and systemic corticosteroids with this treatment. Now, does it come with a high price in terms of adverse events? Not really. This drug is very tolerable. The only thing we sometimes see is reactions to the local injection. This is a self-injection the patient can do at home. So injection site erythema or injection site reactions are somewhat higher. Otherwise, so far it is very tolerable. Of course, we need to get more information and more experience on thousands of patients with this drug to make that statement at the end. There's another monoclonal antibody, Omalisumab, which we all know very well from treatment of asthma and chronic urticaria. And also in that patient, in that drug, there was a trial where Polyp 1 and Polyp 2 with less patients, about nearly 300 patients in these two groups, just showing again the proof of principle anti-IgE is working in these patients with CRS, with nasal polyps. These patients look a little bit different in terms of that they were not asked to have formal surgery or systemic corticosteroids, but they are quite comparable in terms of characteristics such as nasal polyp score, loss of smell, systemic steroids in the last year. And again, here we see an effect on the nasal polyp score in these two trials and the nasal congestion score. Although you remember we just had a -2 score over 24 weeks reduction. With dupilumab here, we're talking about a -1 score reduction. We have an effect on smell also, the UPSID, the total nasal symptom score, and of course SNOT-22 as a sort of quality of life parameter. And again, this drug is very well tolerable. So in fact, summarizing all that, we have identified mechanisms that make our patients suffer more, that make them resistant to treatment, that make them to the standard treatment, that make them more likely to have comorbid asthma. This is type 2 inflammation, and we have developed new methods of approaching type 2 inflammation, and that is depicted here on this red rectangle. If you realize that your patient is type 2, and again, we will talk about how we identify type 2 inflammation, then in the future, there will be treatment possible with a different kind of surgical approach, with biologics, or with a combination of two, even more underlining the necessity of endotyping your patient. And with that, I thank you for listening, and I'm looking forward to your questions. Thank you so much.
Thank you very much, Professor Bachert, for your excellent talk. And we've had a very nice overview on chronic rhinosinusitis, from the mechanisms to the phenotypes, endotypes, and to the most current treatment strategies. I'd like to now invite Professor Lau to give his talk. And after he gives his talk, we will have a discussion between the two speakers.
Good day, ladies and gentlemen. This is Zhang Luo from Beijing ThongRen Hospital and Beijing Institute of Otolaryngology. First of all, I would like to thank my friends for inviting me to attend this special web symposium this year. I will talk about the phenotypes of chronic rhinosinusitis with nasal polyps, especially in Asia, and how that influences our daily practice. In the review Claus and I published 5 years ago, we drew this world map to show the current prevalence of CRS in the world. You can see chronic rhinosinusitis is prevalent in 8 to 11% of adults in Europe, 5 to 12% in North America and Brazil. As you all know, China is a large country with a 1.4 billion population sitting in the East Asia. The prevalence of CRS in China is 8%, which is close to the neighboring country, Korea. So worldwide, CRS is a very common disease, which can be phenotypically divided into CRS with nasal polyps and CRS without nasal polyps. I'm going to focus on CRS with nasal polyps. These are the apples I usually eat in Beijing. You may eat different apples like these. We can tell the difference from the appearances of different kinds of apples. However, for nasal polyps, it may not be that easy. Here is a Chinese polyp. Do all the polyps in the world look the same? I suppose they do. We published a multi-center study in 2016 demonstrating the diversity of inflammatory patterns of nasal polyps in the world. The study involved 2 centers in China, 1 in Japan, Adelaide in Australia, Berlin and Benelux in Europe. We collected samples from these centers and we measured different cytokines in polyps. This figure summarized the cytokine expression in polyps from different regions. Generally speaking, these results indicate, again, that polyps from Europe are closely related to L5, which is a Th2 dominant pattern. The single L5 positivity is lowest in China, and the total L5 positivity in Beijing is close to Japan and Australia, consisting of mainly Th2, Th1, or Th2, Th17 mixed patterns. So, the polyps from different regions may look the same. They are actually different in terms of inflammatory patterns. Then we focus on Chinese patients with nasal polyps. In history, nasal polyp was believed to be more like a unified disease with common histological characteristics. It was reported that most polyps were characterized by a Th2 inflammatory pattern involving cytokines L4, L5, L13, and IgE. One of the most common pathological features of nasal polyps was eosinophilia, as described in this classic rhinology textbook edited by Kennedy. This is a classic pathological classification of polyps proposed by Hellquist 20 years ago. As you can see, the most common type is edematous eosinophilic type, 86%. Actually, a few studies showed that eosinophilic infiltration was extremely common in nasal polyps. been presented in more than 76% of the European and American patients. For example, in Finland, the eosinophilic infiltration was as high as 94%. However, polyps from Asia are different. Previous studies have demonstrated that the cellular composition of nasal polyps in Asia differs from that in Western patients. In Japan, as early as 1980s, only 60% of a large serial showed prominent eosinophilic pattern of inflammation. After that, two studies reported similar percentages, 60% and 63%. The other two studies reported lower percentages, only 32% and 36%. Low percentages of eosinophilic inflammation were also reported in Korea, 32%, 33%, and 63%. Malaysia, 51%, Singapore, 63%, and Thailand, only 18%, which is astonishing. Now, we all may have the impression that eosinophilic nasal polyps were less common in Asia. However, before we make a conclusion on that, we need to realize that previous results were based on variable definitions of eosinophilic polyps. Therefore, it is not reasonable to compare studies using different definitions of eosinophilic polyps. The definition of eosinophilic nasal polyps is not standardized. Actually, our collaborators in Ghent University have carried out two studies to directly compare Belgian polyps with Chinese polyps to see the differences in the inflammatory patterns. In the first study, the ECP-MPO ratio was significantly lower in Chinese polyps. Meanwhile, Chinese polyps showed significantly lower eosinophil and neutrophil counts than Belgian polyps. In the second study, Chinese polyps showed much lower percentages of eosinophilic inflammation. Both studies indicated that Chinese nasal polyps were biased toward neutrophilic inflammation compared to Belgian polyps. This is the study we've carried out in my department. We have counted the tissue eosinophil percentages in more than 380 patients with nasal polyps. Here is the distribution of tissue eosinophil proportions. When we use a cutoff value of 10% for tissue eosinophilia to analyze the inflammatory pattern of our patients, 68% of our patients were defined as eosinophilic nasal polyps. We then compare our result with others which use the same cutoff value. Not surprisingly, ours is consistent with two Korean results and the second generation of Asia in the United States. A little bit lower than Japanese result, 76%, but significantly lower than data from Europe, reporting 88%. In the review published 2 years ago in IFAR, we have summarized the current criteria for eosinophilic nasal polyps. This table shows the tissue eosinophil numbers per Hepar field, which are used as cutoff values, varying from 5 to 350 per Hepar field. Regarding the tissue eosinophil percentage, the cutoff values vary from 5% to 50%. These results suggest that the cutoff values of eosinophils as the diagnostic criteria of eosinophilic nasal polyps are subject to change with geographic and ethnic differences. There is one more thing I want to bring your attention to, is that within the last 2 decades, there was evidence from Thailand and Korea showing the polyps in Asia seems to be more eosinophilic. This study from Thailand, which was published in 2013, reported that over a period of 12 years, there was a 7-fold increase in tissue eosinophil number from 5 per Hepar field to 35 per Hepar field. At the same time, the study from Korea reported a similar result, that over a period of 17 years, the proportions of eosinophilic polyps doubled, increasing from 24% to 51%. This eosinophilic shift indicated that the inflammatory pattern may change over time. This recent study from Beijing compared polyps tissues took from 2003 to 2004 with those took 11 years later. The eosinophil percentages in the tissue nearly doubled, increasing from 20% to 39%. Using a cutoff value of 10% for tissue eosinophil percentages, the percentage of eosinophilic nasal polyps increases from 59% to 74%. Therefore, nowadays in Beijing, China, eosinophilic nasal polyps has become the predominant subtype. At the same time, in Wuhan, as we can see, the eosinophilic nasal polyps was significantly lower, only 44%. As a surgeon, I'm operating on nasal polyps all the time. You are looking at 2 patients with nasal polyps who have both received appropriate medical treatments and endoscopic sinus surgery. The preoperative CT scans and the postoperative images. While one group of patients, like these female patients, shows good response to surgery, the other group of patients, like the male patient, shows recurrence. These patients have been classified as refractory or difficult patients. The question here is, among so many factors which may cause the difference, what the most causative factor is? If we can find that factor, can we then predict the outcome of the surgical treatment? We have successfully linked the inflammatory patterns of polyps with the surgical outcome by using cluster analysis. In this retrospective study, we recruited 366 patients with polyps who received endoscopic sinus surgeries and appropriate medical treatment. With a mean follow-up time of nearly 3 years, it was surprising to find out that the recurrence rate was as high as 57%. I have to tell you that number is really a depressing one, because when I asked the surgeons around me about their cure rate of the surgery, they always said, I cure most of my patients, let's say 80%. We need to find out the underlying mechanisms. So we counted 4 major kinds of inflammatory cells in polyp tissue. Then we did hierarchical clustering of 4 mucosal inflammatory cell percentages, and this heat map shows the result. Each tiny row represents 1 subject, and each column represents 1 inflammatory cell proportions. On the left, the dendrogram shows similarity of the groups, and on the right, the clusters are indicated by vertical bars. So totally, there are 5 clusters displaying different inflammatory patterns. Here are these 5 clusters. As you can see, cluster 1 is a plasma cell dominant cluster. Cluster 2 is a lymphocyte dominant group. Cluster 3, mixed group. Cluster 4, a neutrophil dominant group. And finally, cluster 5 is a eosinophil dominant group. It is interesting to find out that the follow-up results of these 5 clusters are quite different, ranging from 5% to 99%. Cluster 1 and cluster 2, which are characterized by either plasma cell or lymphocytes, have good surgical responses, and the surgery might be an appropriate approach for these patients, who totally accounts for 37% of all patients. On the other hand, almost all the patients in cluster 5, which is characterized by eosinophil, will have recurrence in response to surgical treatment. We classified polyps into 5 cluster 5 when the percentages of eosinophils in the tissue is more than 55%. In clinic, these are really difficult patients. In a study we published this year in Rhinology, we have investigated the long-term outcomes of different surgical strategies for patients with nasal polyps and asthma. Patients were randomly assigned to receive functional endoscopic sinus surgery, radical FAS, or radical FAS plus draft 3 procedures. Although the patients receiving radical FAS or radical FAS plus draft 3 yield better short-term outcomes than did FAS, the recurrence rates after 5 years is 96% in all three groups. In our daily practice, we are expecting to use certain biomarkers to predict the outcome of surgery. So we divided our patients into two groups, the recurrence group and the non-recurrence group. These are two representative photos from the two groups respectively. The left one shows an eosinophil dominant polyp with recurrence, while the right one shows a plasma cell and a lymphocyte dominant polyp without recurrence. When we compared the variables between the two groups, we found these 13 factors are significantly different between two groups, including the Lund-Mackay score, olfactory score, rhinorrhea score, facial pain headache score, comorbidity of asthma, oral phenol, and tissue and blood eosinophils, tissue and blood neutrophils, plasma cells in the tissue, and both tissue and blood lymphocytes. We introduced these variables into a multivariate model to determine the factors which are associated with polyp recurrence by using logistic regression analysis. And the multivariate analysis revealed that two tissue eosinophil markers, both percentages and absolute count in the tissue, and phenol were significantly correlated with recurrence. Then we drew these receiver operating characteristic curves for these three parameters respectively, showing that both the percentage and the absolute count of tissue eosinophils were good predictors of recurrence. Actually, the areas and the curves of both markers are identical, which is 0.969. The next step is to define tissue eosinophilia to predict the outcome of surgical treatments in reality. In this case, we determine the best cutoff values for those two tissue eosinophil markers by calculating the Uden index. We found both a cutoff value of 27% for eosinophil percentage and a cutoff value of 55 for absolute count, exhibited good sensitivity and specificity. When using McNamara test, the comparison support that the predictability of tissue eosinophil percentages was better. These two figures show how the two cutoff values nicely discriminate the two groups of patients respectively. Here, we go back to the previous cases to show the results of tissue biopsy. The upper case without recurrence shows a tissue eosinophil number of 30, which is lower than the cutoff value of 55, and the percentages is 21%, which is also lower than the cutoff value of 27%. The lower case with recurrence shows a tissue eosinophil number of 300 and high percentages of 58%, both higher than the cutoff values respectively. Actually, we have to do revision surgery to this patient. The biopsy shows again high values of 2 tissue eosinophil biomarkers, indicating a high chance of recurrence later. This study was published in 2015 in the American Journal of Rhinology and Allergy. Interestingly, a multi-center study from Japan also reported that tissue eosinophil number was correlated with recurrence, and a cutoff number of 70 showed the most significantly difference, which is pretty close to our number, which is 55 per hectare field. Actually, in the review article published 2 years ago, the authors totally identified the 11 papers with 7 cutoff values that reported high tissue eosinophilia associated with recurrence, and they found a cutoff value of more than 55 per hectare field showed the highest sensitivity and specificity. Therefore, 55 per hectare field is recommended for predicting the likelihood of recurrence. You are looking at the integrated diagnosis treatment algorithm for precision medicine in chronic rhinosinusitis, which we published last year. Current management algorithms are unable to achieve and maintain optimal disease control, especially in clusters with high eosinophilia. The identification of patient subsets and effective biomarkers is important for optimizing biotherapeutic strategies. So in summary, sinonasal tissue eosinophilia is present in the majority of nasal polyps, but is currently more common in the West society than in the East society. CRS endotypes vary accordingly to geography and ethnicity, and their distributions change over time. We have defined 5 clusters of nasal polyps, which are distinct for polyp recurrence on the basis of the predominant inflammatory cell types. We can use both tissue eosinophil proportion and eosinophil count as good indicators for predicting the nasal recurrence. These are my colleagues who have contributed to the study. I would like to thank our collaborators at Ghent University. Again, Claus and Nan. They are climbing the Great Wall. And I thank you for your listening.
Thank you very much, Professor Luo Zhang, for the excellent talk and for giving this overview about the Asian perspective. I think we have had 2 excellent leaders, global leaders on chronic rhinosinusitis, talking about the phenotypes, endotypes, the pathophysiology, the different characteristics or inflammatory cell types, the clusters, and the potential treatment strategies. I'd like to now invite Professor Bachert and Professor Luo Zhang. Professor Bachert is also an international advisor to our the APAAACI Rhinitis and Rhinosinusitis Committee. And Professor Lau is, of course, the chair of our Rhinitis and Rhinosinusitis Committee, as well as he is our treasurer of our organization. So I'd like to leave the podium for both of you to have a discussion that would be very excellent for our audience. So Lau and Claus, please.
Well, thank you, Ruby.
Thank you. Very nice to see you, Klaus.
Hi, Luo. It is a long time we didn't see, and I hope it will change in very, very near time. I think you made very good conclusions on looking at the same thing actually by using the eosinophil as a marker, which has advantages and also disadvantages. The advantages is simple. You can do immunohistochemistry, you can use histology. One question I had was, did you look at the peripheral blood eosinophils? Did they indicate in those patients that there was a type 2 or eosinophilic disease in the nasal polyp region? Because it's a small organ, the nose, it's not so big if you compare it to asthma, of course, where you have the lungs inflamed, and we know that eosinophils go up in asthma and type 2 asthma. So did you look at that? Is that of any value to define type 2 or eosinophilic disease in your patients?
Well, unfortunately, we haven't looked at that yet, but I think that's a very good suggestion. And currently, we are focusing on those biomarkers, especially the cellular biomarkers, but I think more markers should be found. Also, I would like to ask you about your reboot surgery. I noticed your paper last year, and that's a small samples. I'm sure you have more patients now. So how about your new view on that? What kind of patients should receive the reboot surgery? Do you have any indications of the surgery now?
Well, first of all, thanks for the question. We have looked at more than 70 patients currently who are sort of in the 3rd to 5th year. The recurrence rate is still clearly under 10%.
Oh,
so that's great and clearly lower than we have seen before with endoscopic sinus surgery. I think we have to talk about what reboot really means. It means that you completely, I don't like the term radical, but completely remove the sinus mucosa. And that is, of course, quite some work. And I think the colleagues sometimes do not understand that you really need to use a 30, but also a 70-degree optic. Otherwise, you cannot clear the maxillary sinus completely. We do not regularly do a draft 3, but we do it in quite some patients, certainly the ones with recurrence. So had former surgeries and still recur, and they really want to get rid of it. And then we sort of also do a draft 3 and also clean the frontal sinus completely. We have noticed that as a consequence of that, you get some scarring, certainly in the maxillary sinus. Sometimes it stays open nicely. Sometimes it sort of is just a little rest of the original maxillary sinus, but we have not seen problems with that patients suffer from anything because of that. So I'm quite happy with this surgery under these conditions, and we certainly indicate it in patients who are sent to us for revision or revision of the revision surgery, where you want to offer something else. And certainly in new patients, if there is a asthma with it, so we know for sure that this is type 2, where we see increased eosinophils above 300, and we know that if you would not do a reboot, you would have quite some recurrence. We do it also in primary patients.
Also, in your paper, you mentioned some of your patients received partial reboot surgery. So
yeah.
How about the outcome of a partial reboot surgery?
Yeah. So if you do partial, which means not the frontal sinus, you sort of just open the frontal recess, you take the polyps out, you reach from there, but not more. Then you can have a polyp growth in the sinus, the frontal sinus, and sometimes you have to, from time to time, remove the polyp which comes out of the frontal sinus. In that case, I would always offer the patient, okay, we can do another surgery and also remove that mucosa. Only if they would develop symptoms like pain in the frontal sinus, then I say, well, it's time to do that. So I leave that a little bit to the patient, whether they from time to time come for that. But it actually indicates very nicely the effect of the reboot of the other mucosa, where you don't have polyp recurrence, versus the frontal, where you didn't do the reboot, and you have, of course, growing polyps there. So I'm absolutely convinced that it's a local mucosal problem. And how that changes with the advent of the biologics is another question, because I think we all understand that reboot surgery, extended surgery is not for everyone and not for every practice, and it is sort of certainly limited to certain centers that can do that kind of surgery.
How about we leave the sphenoid mucosa? The most difficult part should be the frontal mucosa, and the second difficult probably is the sphenoid mucosa. So I think it's quite easy to remove ethmoidal mucosa and a little bit difficult to remove maxillary mucosa. So how about we do partial reboot, leaving the sphenoid and frontal sinus untouched?
Yeah, so specifically the sphenoid is a miracle for me in a way that it's quite often involved in this disease we have in Europe. I normally open it widely. I try to control it completely. Of course, I make sure the carotid is covered with bone and things like that. And I was so far quite successful in that way that I don't have a problem from the sphenoid sinus. Also, the frontal sinus problem is not a big one. It's a few patients. So, in those patients, the question is always how extensive do you have to be in everyone to cover those with more extensive disease. And I'm a little bit conservative here. So the thing I would offer first is really the conventional partial reboot. There is a recent paper from Spain where they actually made a mucosal flap from the floor of the nose. So they do a reboot as described by us, and then they put this floor of the nose flap to the ethmoid. Of course, it doesn't cover the whole ethmoid, but it's sort of a starting point, and maybe it is, speeding up the coverage of the ethmoidal and mucosal and maxillary sinus bones by mucosa. Although I think we don't think it's necessary, because after 6 weeks it's anyway covered, 4 to 6 weeks. So in those patients where you have recurrent surgery, the patient maybe doesn't want to have another surgery. What about biologics in Beijing? Are you already using biologics, and in whom?
Well, we are just at the starting point. Currently, the only biologics we can get is Omalisumab. So we have about 30 to 50 patients receiving Omalisumab. So actually, I really want to ask you a question on that, because I know you are the leading person in the world using biologics. So how we combine biologics with surgery? So how do you choose this method for the patients with nasal polyps?
Yeah, that's a very good question. Actually, it's a key question to the whole story. I would say, well, at a certain moment, you have to be sure you have uncontrolled severe nasal polyposis. If you have a former surgery, and you know from that former surgery, for example, that there were eosinophils in, and that's what the pathologist describes very often, then you're also sure that this is type 2 or eosinophilic. Of course, you can measure, certainly for Omalisumab, you have to measure the IgE levels in the serum because there are certain limitations you have to follow. But otherwise, what we figured out is you actually have two ways. You give the biologic first, or you do the surgery first. I would clearly vote for give the biologic first. Or in other words, you have a patient at a certain moment where you decide that this needs a long-term approach. And at that moment, I would give the biologic first, because first, maybe you don't need surgery in some of these patients, as we have seen in our dupilumab study. So it's certainly good to give the biologic first, because it also enables you to see the response to the drug. As I said, some patients, they have no polyps anymore afterwards. Some patients do not respond at all. And we have about a third of the patients which otherwise fulfill the criteria of type 2, where a type 2 biologic still does not work, which we don't understand. Maybe partially this is neutrophilic inflammation, as you pointed out, as mixed type also. Maybe there are other reasons. But anyway, if we do not have an answer, if we do not have a response in reduction of the polyp score and the symptoms, and I would certainly want to see it in the polyp score, then of course, why would we continue with this drug afterwards? So if you give the biologic first, it enables you to see the response to the biologic, and it enables you to also spare surgery in some of these patients. And then I would do surgery, and you can do that surgery if necessary, of course, still under the protection with the biologic. We have done that in several cases, and what you see is a wonderful, fast healing process, because type 2 is not good for the epithelium, as we all know. It disturbs epithelial integrity. So wound healing is also not good at the moment you have a type 2 inflammation. So the combination of first biologic, then do the surgery for the rest of the polyp mass, and continue to do your biologic treatment, I think is the best option.
So what is the suggestion on the length of the biologics treatment? So totally 1 year or half a year?
Well, we know from studies that you might see response within 4 to 8 weeks. But I think you should have a 6 months treatment to really figure out, is there a response or not? So that's 6 months. Once you see that there is a response and you want to continue, there is no end to it. And that's a little bit the disadvantage of this biologic therapy, because certainly also of the costs, not so much of side effects, but of course this is a tremendous cost. And the point is, again, selection of patients. In whom would you do that? Obviously in those where standard of care otherwise cannot achieve control of disease.
Good, really good. I think we learn a lot from your experience, and also we are currently under investigation of L4 alpha receptor 2. So, well, probably my last question is on the definition of eosinophilic nasal polyps. So, what is your view of eosinophilic polyps at the current stage? After 30 years. So how do you look at these questions?
Yeah, I mean, as I said, the eosinophil is actually a good marker. In our group of patients where we had severe uncontrolled nasal polyps, type 2. So we retrospectively analyzed them again after looking into the mucosal expression of cytokines, and you have IL-4, IL-5, IL-13, and a lot of others. And that was the other thing I wanted to say. If you look at eosinophils, you're sort of missing out all the chemokines, the TARCs, the PARCs, IL-33, TSLP, all of the other mediators, where I'm quite sure that there will be new therapies and even more therapies, biologic therapies, coming in the near future. But if you look at these severe patients and you take asthma comorbidity as a first in our population, I think you should test that also in every population, depending on the world where you are. If you have comorbid asthma with severe nasal polyposis, you are 95% type 2. So do we reach 100? Do we need to reach 100%? 95% I think is quite good. So you're quite sure that this biologic would then work. If you do not have comorbid asthma, then you need a eosinophil count in the peripheral blood of 300. Doesn't need to be at that day, but in the last half year, any count from the peripheral blood that has been shown to be higher than 300 increases your chance, even if you have no asthma, to again more than 95% when you have severe nasal polyposis. So I think these are two parameters. We still miss some patients where then of course you could take a biopsy, or you could take nasal secretion measurements, but nothing is standardized here, so we don't have a diagnostic tool yet for that. If you do a biopsy and find eosinophils in the biopsy, as you very nicely showed, you also have a clear hint of a type 2 immune response.
So I think the most important parameters, we should look into the tissue and find out what kind of a TH inflammatory pattern the patient had. Is that correct?
Yeah, I mean, the real difficult questions still come, and that is, which of these biologics would you use in what patient? And so far, we do not have, we miss head-to-head studies, we miss, a better selection of these patients based on different parameters of their immune reaction locally. So we are far away from understanding that optimally, and the current approach is more or less that you take the one that helps most. And
yeah, I think always there's a lot of unknown answer questions ahead. So we are hoping that we can get back together to normal. The situation in China is getting better and better. I hope European also. So can you expect, when can we meet again in person in the future?
I'm at the moment actually seeing a possible second wave in Belgium. The numbers are now increasing again. It's not as high as it was before, but it's not a good sign. We don't have the death rate yet that we had before, but the infection rate increases. We see very similar things also in Germany, although slower. I'm afraid it's not at the end. But I think on the other hand, there's vaccination, there's hope on that. We have looked into other therapeutical principles, also targeting ACE2 receptor and so on. So maybe we find out something that makes life better and nearly normal, even if the virus is still around.
Yeah, because actually we are having a vaccine in Beijing already. So I hope I can do soon in Beijing, probably early next year. I mean, that will be the first year we haven't seen each other during the last 10 years, I think.
Absolutely, we should work on that, and I hope it works. although in Beijing, how difficult is it to find infections? Because you can only show that it works if you have infection around.
Exactly. Well, nice talking to you, Klaus.
Yeah.
I think that's the end of the discussion.
Yeah, I have some questions. Actually, very nice discussion, Lau, and Klaus, really brilliant, and I think you've covered. So I have some questions, a few questions. One is, Klaus, like when we talk about, we talk so much about the local IgE synthesis and, that being an important marker. When we talk about omalizumab, do we really have to look at the local IgE levels, or are we just going to base according to the systemic IgE? Because often the systemic IgE levels are not that high. So how do we titrate that? That's one question.
It's a very good question, Ruby, and I have no answer to that. Because very clearly there is no direct correlation between what you find in the serum and what you find in the tissue. To define an IgE in nasal secretions, for example, or in the tissue is not standardized, so we don't know what the consequence of that is. We treat according to the rules for asthma, which is you look at the serum IgE and the weight of the patient, and then you make an assumption what you find in the nasal polyps. Of course, this is not correlated at all. So in other words, you're absolutely right. You could, in some patients, maybe by doubling the dose, reach something that you don't reach with the recommended dosage, but we don't have any evidence on that. So currently, we cannot help in that anymore than saying, well, hopefully in the future we know better.
My other question is like, you talked about doing the, giving the biologics prior to the surgery. And conceptually, I think that's really quite logical because you're down-regulating the inflammation. It also helps the surgical procedure itself, and also probably the recovery, as you mentioned. Well, what I was wondering is, do you have any data that doing the giving the biologic prior to the surgery would actually reduce the rate of recurrence?
Yeah, but again, okay, we have data of corticosteroid use prior to surgery, making the surgery easier, so to speak, but that has no influence on the recurrence rate. The principle, I don't think that we really are ready for a principle that we give a biologic, let's say for 3 months, then do the surgery, and the recurrence rate is less. We have no data on that, and I don't believe in that principle. I do think that unless you really do a reboot, you have to continue with the biologic.
Thank you very much, Klaus. Lau, my question to you is like, you talked about the different clusters, and I was looking at some of the older classification of nasal polyposis where we used to have like the eosinophilic inflammatory type, the lymphocytic fibrotic type, the plasma type, and then the glandular type. And this is like, I mean, it's still different, but also quite similar in characteristics in some way. So how would you kind of place this in context of the older classification? Do you have some idea about it, or would you like to make some?
Yes, actually, the new clusters are quite different from the old one, because the old classification only see different inflammatory cells individually, like they only count the plasma cell, lymphocytes for the classification. But the new clusters, they actually see at least 4 different inflammatory cells and combine this criteria together. So when we talk about the eosinophilic type, we are not only see the eosinophilic cells, but see other cells also. But the dominant inflammatory cells is eosinophils. So it's a new one, not as same as the old classification.
Thank you very much. Now, my other question actually comes to both of you because, this is because, I still remember, Klaus, when you and Dan used to talk about eosinophilic polyps, and I used to argue that because in Japan we never saw eosinophilic polyps in those days, and we used to have only neutrophilic polyps. And like I said, no, well, CRS is with nasal polyps is not eosinophilic. We have just neutrophilic. And as you and Lau have presented today again, how clearly that the pattern of the characteristics, especially the data that Lau showed in Thailand, showing an increase in eosinophilic type of nasal polyposis. We're moving away from the neutrophilic type. Now, I just wonder if this is something to do with the diet we have. Is it something to do the environment we live in? Is there some epigenetic factor? Why is this change occurring in the Asian population that's driving us towards to an inflammation similar to the West? I mean, I know this may be a very difficult question to answer, but even if you have some hypothesis, I'd like to hear from the both of you.
Well, Ruby, first of all, this is a $1 million question, I would say. If you can give me the answer, I pay you the 1 million. No, I really, first of all, I think it was very clear from both of these talks that there is no pure eosinophilic nasal polyps. And we have shown recently that even if you have a very severe eosinophilic inflammation, and that might be still a difference between what we see here frequently and what you see in Asia, that they are eosinophilic but not as severe. Now, if you have this severity and you have sarcolytin crystals, this induces a neutrophilic inflammation, which is totally independent from IL-17. So in order to understand, it's getting more and more complex, and we should very clearly figure out, if you have eosinophilic inflammation, if you have type 2 inflammation, is a mixed inflammation, a mixed severe inflammation. Plasma cells, of course, are also there, because they produce IgE, and there's an increase in these immunoglobulin production. So it's not just one cell type. And the other thing is, what was your question? Sorry.
Yeah, I was saying whether the diet or the epigenetics or something in our environment is causing this change.
My favorite thing, although I cannot prove it, certainly is the microbiome, because we know that quite some, not just Staphylococcus, also Haemophilus and others, can have quite some impact on the immune reaction. And I would guess, although I don't have a proof for that this plays a role, in the change in Asia, that at least I would look into the microbiome, maybe even virome. Yeah, we don't have the data, but that would be my favorite target.
I would like to resolve 1% of this 1 million questions. I mean, last year we published a paper in JACI showing that epigenetic factors can, influence the inflammatory type of nasal polyps. We are actually looking into the L8 epigenetic variations. That means epigenetics works, that's for sure. On the other hand, although with the same genetic background in China, the polyps from Chengdu, from Guangzhou, and from Beijing are quite different. And Klaus have a very good experience on that. So in China, we have the same genetic background, but we still have different inflammatory patterns, which means diet or microbiome influenced by the food habits. Probably the spicy food in Chengdu influenced the inflammatory pattern. That's the possibility, I think.
Yeah, thank you very much. I mean, these are very, very important areas, and we are also working on the microbiome. So I'm glad that you brought it up, and that's the reason I mentioned diet, because diet or epigenetics may have influence on the microbiome in early life and program the child to develop that later on in life, although you don't have nasal polyps in very young kids, small kids. So my other question is, like, say, for example, the microbiome may have some role. We don't know yet, but there's some small data that's come up, like on Lactobacillus sakei and all. It's a small study. So do we have any, if not even a strong evidence, but any potential role for probiotics or prebiotics? Do you think that could be one of the areas to investigate, or if we don't have it now, but one of the areas to investigate to probably prevent the development of nasal polyposis?
Well, that's a $1 billion question. Because if you have a probiotic that would do that, I think you're a rich woman. No, honestly, because it would also prevent other late onset disease. What we have to understand is we are talking about, IgE, we're talking about eosinophils, but we have to do with totally different diseases, early onset, late onset. What's the difference of that? Why are there different mechanisms and maybe different therapeutic or preventive measures? So in my eyes, we are far from guessing something like that. And as I know that there's a big interest in selling probiotics, I keep myself totally covered.
Do you have any comment, Lau?
No, I have no experience on the diet research, so probably those different kinds of food or wine could work on the microbiome, but I don't know.
Yeah, I think so. That especially when you describe the differences between Chengdu and Guangzhou and Beijing, I think this itself, that even within the same genetic population, that what are the differences that actually lead to this? I know it's very difficult unless you have a standardized protocol, looking at all the different areas and under very probably even in early life. And follow them up for several years, not knowing whether they're going to develop polyps or not. But if some studies like that could be done on a longitudinal basis, I think we could probably come up with a good answer. So in any case, go ahead, Klaus.
Just a remark. To my knowledge, there's not much known about hereditary factors that would help us a little bit, understanding better. So there's a lot of work out there, as you correctly point out.
Thank you very much, and thank you, Klaus, and thank you, Lau, for the excellent. I think this was a brilliant session, and I think our membership, APAACI, and even beyond, would be so delighted to watch this, and this will be on the APAACI YouTube in the near future. And we look forward to your valuable contribution as a series that we should do. I think this is very educative, informative, and also could stimulate new research in different countries. So thank you very much, and I hope we can meet each other. What was one last question I forgot to ask is that, do you have any points regarding COVID and chronic rhinosinusitis or rhinosinusitis? Is there any data at all as a comorbidity?
We have looked in our patients. We don't find a lot of nasal polyp patients with COVID or CRS patients, not increased really here. So I don't think it's an increased risk for these patients, nor do we know that it's an increased risk of having severe COVID. So we don't see too much of that.
Anything, Lau, from your side?
Well, actually, we submit a paper to allergy is now under revision. We are showing that the severity of the virus probably related to different inflammatory pattern of nasal polyps, which means the non-eosinophilic polyps patient may have a high chance of virus infection. But we're going to, I think we're going to publish that this year.
Oh, wonderful, wonderful. I mean, when we look at asthma, actually, it's very interesting that normally you would expect viral infections, asthma being a risk factor, and the asthmatics being more prone to developing viral infections, but the comorbidity of asthma is almost not there. We also just published a paper in Allergy, but it's more of a letter to the editor. But again, that's interesting. So we should also work in that space and see what we can find in that area, since we have to probably live with this for some years.
I'm afraid so, yeah.
And hope we can see each other, if not virtually, but in reality. Miss that in-person contact.
Okay.
Thank you very much.
Thank you much. Thank you much, Ruby, and appreciate that very much. And all the best to you.
Take care.
Thank you.
Bye-bye.
Bye.